Good evening, respected doctors, distinguished speakers, and esteemed guests. I hope आप सबने lunch कर लिया होगा. Now we are starting our session. So I would like to call upon the stage our chairperson, sir, Dr. Divakar Singh. Sir, please. And our speaker, Dr. Atul Hirani, sir, from Hyderabad. Harsh, sir. Yes, sir, please welcome to our stage. And his topic is CGM Insight, Time Below Range and Avoiding Hyperglycemia, a case-based discussion. Sir, please.
All right, so a very good afternoon to everyone. It's indeed a great pleasure and privilege to be here. So I want to extend my warm greetings to Dr. Ashutosh sir, Palvi ma'am, Dr. Veneto sir, Nupur ma'am, and also Hirani ji for organizing this fantastic initiative right at the heartland of Varanasi. So with this brief acknowledgement, let me start my session. There is no conflict of interest, no declaration for this session. So I'm going to talk briefly on significant time below range and the aspect of avoiding hypoglycemia, and we will be looking at from a lens point of case-based discussion. So we'll be discussing 4 to 5 different cases of hypoglycemia significantly picked on CGM and what's the interpretative outcome we want to establish with this. So as we are all aware, 11%, close to 11% of adult population is expected to be having diabetes right now in India, and each hypoglycemia episode leads to horrendous expense of healthcare cost, especially if there is an admission which is required for a hypoglycemia episode. And close to 74% patients modify the treatment regimen self due to one experience of hypoglycemia concerns. So today we'll explore why it matters the most and how CGM is actually changing the way we perceive hypoglycemia and we act little early and faster. So let me define hypoglycemia from CGM perspective. So the time below the range metric, what we are aware of in interpretation of CGM, has 2 cutoffs. The time below range level 1, which is 70 mg per dl hypoglycemia, which is an alert threshold when we are looking at CGM data of hypoglycemia. When we look at TBR level 2, which is less than 54 mg per deciliter, which is considered clinically significant hypoglycemia. When we are looking at CGM readings, because we have to understand CGM takes readings from interstitial space. So the target of time below range, what is expected, like there should not be hypoglycemia more than 4% of 24 hours for any patient who is on CGM, which is roughly 1 hour per day. So ideally to have 0% of hypoglycemia, but this is the variability which is expected based on major guidelines. So why it is dangerous, we are all aware of symptoms of hypoglycemia, so I'm not going to delve into it much now. But let's look at the cognitive component of hypoglycemia, where 56% of risk in dementia is there after one severe episode of hypoglycemia, and this risk doubles with recurrent episodes. So brain health is directly linked with glycemic stability, and each severe hypoglycemia episode, as we saw, has a huge toll on the expense. And we already are aware that multiple metrics of CGM can actually help us understand when to actually suspect a true hypoglycemia on CGM. So let me start with the first aspect. So when we look at a CGM report, one of the first columns we see is sensor active time, as in for how many hours or what percentage of 24 hours or what percentage of entire 14 days was the sensor fully active, as in the recording was happening. Now this minimum requirement is 70%. So more than 70% of 14 days, there should be the sensor activation time. The second aspect is time below range assessment. So if we see time below range of more than 4%, that is a marker or addressal of hypoglycemia approach. Like when do we really approach hypoglycemia? When we see time below range more than 4%. Then we identify vulnerable time blocks of hypoglycemia across the 24 hours. Starting with one of the most common blocks of hypoglycemia across 24 hours is a typical one of 3 a.m., which is one of the most dangerous because there is no protective food intake as most of the patients are in sleep. Then comes a midday hypoglycemia window, time window, which is somewhere around 11:30 to 1:30, which is typically between breakfast and lunch gap or a pre-lunch time hypoglycemia. The third window to always watch out in a CGM report is 5 p.m. hypoglycemia. Typically, this is because of morning NPH insulin. If it's given, the peak of NPH happens somewhere around 4 to 6 p.m. and that peak triggers a hypoglycemia possibly. And often many of our patients don't take the snacks despite repeated explanation to them that if you are on this type of insulin, you are supposed to have a snack at 4 p.m. to prevent this dip in sugars, but often they don't listen or forget. And the last one is post-dinner hypoglycemia. Very rare but very common because excess bolus insulin or there is an excessive evening exercise before dinner is a factor which leads to a post-dinner hypoglycemia as well. So let's understand few other key metrics. So coefficient of variation, if it is more than 36%, these are all, as we know on CGM report, on the first page itself we see these metrics efficiently quoted. If it's more than 36%, that means it's high variability, there is a higher risk of hypoglycemia. So the range of variation between a low sugar and a high sugar is too high, and that wider range is actually triggering to a higher chance of hypoglycemia. So let's look at the real TBR. So how do we really validate? There's no clear-cut guideline which says, ABCD, but then clinically if we look at it, Whipple's triad, finger stick confirmation, symptom correlation and pattern consistency. This is one of the most important factors to look out on CGM. Let's say you see a patient where consistently you're seeing a hypoglycemic window between 4 p.m. to 6 p.m. for 5 to 6 days on the go. That means there's a consistent pattern. The person is going on a regular hypoglycemia. So see, these are the 4 simple factors with which we can anticipate an actual hypoglycemia. And sometimes even symptoms do not manifest because of autonomic neuropathy in our older patients especially. So that is again another factor to be considered about. So 15 to 20 minute lag exists between a classic blood glucose and an interstitial blood glucose, which we should be considerate about. During rapid glucose changes, this discrepancy even increases further. So let's look at false low CGM readings. As in, when do we not believe CGM, right? This is very important to understand. So first is sensor placement issues. We see false low hypoglycemia triggers if the pressure on sensor is exerted beyond a certain threshold. Let's say somebody is sleeping at night, on the right arm the sensor is put, and there is some weight exertion on the sensor, or say a pillow has crushed the sensor between the hand and the bed sheet, you may see a false hypoglycemia. And this will be very typical because it will not be consistent. It will be one isolated, non-explanatory, short interval hypoglycemia, which you will see on a CGM graph. The second is sensor accuracy problems. So many a times we notice that first 24 hours for few sensors, few of the types of sensors, we see a lot of variation. That's why it's called as warm-up period. So when we want to do a follow-up for a patient on CGM, specifically if we are wanting to rule out hypoglycemia, it's always advised to at least let 5 days go by. So first 24 hours plus 72 hours of active time and 1 more day of buffer. So a 5th day would be an ideal day to call for a follow-up for a patient who is put on sensor and we are wanting to suspect or we are looking at suspicion of hypoglycemia. Calibration drift, which fortunately now in 2026 does not exist anymore, because most of the sensors have got the accuracy metrics of MARD, which is mean absolute relative difference, below the 10, which simply means that now sensors are more accurate, more reliable, more well calibrated. So that is the other advantage now we have. Rapid glucose changes we already discussed, and very interesting is medications and substances interference with the sensor. Acetaminophen, one of the most commonly used consumed, some CGM, some models have the issue of interference. Vitamin C, hydroxyurea. So the solution is check device specific interference list. let's say you're using one specific device, look out which are the substances which interfere with the reading sometimes. So that's very important. So I've created a very simple practical validation protocol. First is, let's say on CGM you're seeing sugars less than 70, and on finger stick, on glucometer also it is less than 70. That means there is no doubt here. It's a true hypoglycemia. Please treat immediately. Let's say you see a CGM reading under 70, finger stick is also under 70, but there are no symptoms. But this is also true hypoglycemia. Why? Because the patient may have impaired awareness of hypoglycemia. The third scenario is, let's say there's a CGM reading of under 70, but glucometer shows above 80. Now here there are two possibilities. First is glucometer is lagging by 20 minutes or 25 minutes, and then you repeat it again after 25 minutes, but still if you see a higher reading on finger tip, that means here the symptoms are absent for the patient. If this is the scenario, this is a false low hypoglycemia. Just monitor, do not treat it. CGM reading, if you see less than 70, but if finger stick is above 80 and symptoms are present, please recheck both and treat if the pattern is consistent. Now here it's very important to understand this is only for time below range level 1. Level 2 by default is to be taken as a true hypoglycemia, which is 54 mg per dl and below. So very, very important to understand, because this is interstitial glucose, friends, what we are trying to correlate with. So few special situations: nocturnal false lows, exercise false lows, post-meal false highs also are there. Let's say, if a patient is going for some wedding. Now that wedding they may have more 2 or 3 rasgullas, then it may show a false high just for that meal of the day, right? So these are all the things to be considered about. Heat and humidity, sensor site placement also have some variabilities. So let's start with few cases. So I'm going to discuss one case of mastering nocturnal aspect. So let's say there's a patient, 52-year-old female, type 2 diabetes, more than 12 years, HbA1c 7.2, on a standard regimen of sulfonylurea with an NPH, and the NPH dose is at 10 p.m. once a day. The presenting concerns are night sweats, morning headaches. The fasting sugars are quite high, but symptoms are manifesting at midnight. So the AGP interpretation, if we see, it shows time below range less than 70 of 8%, which is way above the threshold of 4%. And time below range 54 mg per dl below is 3%, which is also very significant, and coefficient of variation is 41%, where the cutoff is 36%. This is above 36%. Now, if we understand the nocturnal glucose fluctuation, there are multiple differential diagnoses which are possible. It could be a Somogyi phenomenon, it could be a dawn phenomenon, it could be even a factor such as insufficient evening nutrition. What if patient fasted and took the insulin? There's a possibility. So there could be an immediate need to optimize the NPH dose. Yes, a dose reduction would be needed. Implement, if the patient can afford, transition to a more ultra long acting insulin. Establish bedtime protocol, bedtime snacking, right? Or optimizing with newer agents of SGLT2 or GLP-1 RA and shifting to a longer acting basal insulin. So all these are possible corrections based on the reason of hypoglycemia. So let's understand this key difference between Somogyi phenomenon and dawn phenomenon from CGM perspective. Very, very important, not from the clinical perspective alone, but from CGM perspective. Now on a CGM graph, if you see Somogyi effect, you will see a low sugar at 3 am. But in dawn phenomenon, the sugar at 3 am will be normal or it will be high. Very strange, but this is how it is. Counter-regulatory hormones will cause a rebound hyperglycemia, whereas in dawn phenomenon, it will be either a growth hormone or a cortisol-triggered rebound hyperglycemia in morning. And higher morning glucose will be a common phenomenon in the both. So the solution is all going to be completely different. In Somogyi, we'll actually reduce the evening insulin. In dawn phenomenon, we'll actually increase the insulin dose of a basal insulin or shift the timing of a basal insulin. So completely different scenarios, but the outcomes are completely different. So I'm going to take this last case considering the time window. We are already at 15 minutes, so I'll take another 5 minutes as the 20 minutes is the allotted session, so I'll take this one. So 35 years, type 1 diabetes, 15 years. The person is a type 1 diabetic and an athlete. Now the person is on a MDI dose, multi-dose insulin regimen, basal bolus, The person is on Lispro and Degludec, 3 times Lispro and Degludec. Now the challenge here is, I'll skip the details for the time part. The differential, so the person is getting on exercise days, the days when the person exercises, the time below range is 10%, and this is maximally observed between 10 p.m. to 2 a.m. So this is actually before the window of a conventional midnight low sugar, right? It's a typical post-dinner low sugar which is manifesting. And coefficient of variation is 38% on the days when the person is exercising, but it is only 28% when there is no exercise. So on the resting day, the variation is lesser. So there is a possibility of exercise-induced glycemic variability, and why this happens is the GLUT4 receptors upregulation persists 24 to 48 hours even after the exercise, and this enhanced peripheral insulin sensitivity actually continues. And in type 1 patient, as we know, the response instability is there. These athletes need a more precise dose correction of insulin. Henceforth, evening exercise actually is triggering overnight vulnerability identified through CGM. So we actually suggest in this scenario to change the timing of exercise, at the same time alter the insulin doses of the post-exercise meal as well. So this is another case. So with this, I'm going to end the session. There are a few more cases, but as we are short of time, I'll just leave it here with this. You can take a picture of this. This covers few scenarios, few patterns of glycemic variability focused on hypoglycemia specific. What is the Indian context? What is the immediate solution? What's the long-term strategy for these scenarios? I've covered in this. And with this, I come to the end of my session with few key takeaways. Specifically in terms of sensor, when do we really replace it? So if you see a sensor glycemic variability of sugars persistently more than 30 mg per dl between the finger stick and the sensor reading, let's say the glucometer is showing 150, but the sensor is showing 200, which is more than 30, or its sensor is showing 110. So the range of variability is above 30 between the sensor reading and the sensor reading. This is where you change the sensor or evaluate if there is anything wrong in the sensor. Multiple unexplained alarms which happen on an abrupt motion, like how we saw the example of the night sleep when the sensor is getting crushed by a pillow, those kind of sensors. If there is a signal loss of more than 4 hours, right, in the sensor, which is actually the sensor active time, if it reduces less than 70%, which means roughly 4 से 5 घंटे 24 घंटे में sensor sugars monitor नहीं कर पा रहा है, that's when you change the sensor. If there is a physical damage or dislodgement of the sensor, or if there is a skin irritation or infection at the site of sensor placement. These are the 5 scenarios where you should replace the sensor. And the golden rule is, if patient has hypoglycemia symptoms, treat immediately, even if finger stick doesn't confirm, even if CGM doesn't confirm. This is most important. So in a nation with 100+ million diabetics, every percentage reduction in time below range enhances lives, preserves cognition, and strengthens our healthcare system. Together we can transform hypoglycemia from a challenge to a conquered challenge. With this, I end my session and thank everyone for this patient lesson. Thank you so much.
Thank you, Dr. Saab. Thank you for a good presentation. Any query from audience? Please question.
One question, please.
Sir, please.
Thanks for an excellent lecture. My question is this. There are 2 or 3 issues concerned with the use of the sticks and glucometer.
Yes.
Many of our patients don't close the lid of the container properly. Basically, this depends on the use of glucose oxidase. The more oxygen that gets inside, the quicker the stick becomes spoiled. So, after the patient has opened it for the first time, and presumably after he has closed it properly, for how many days will you permit him to use the sticks from the same container?
Sir, thank you for this question. This is a very important challenge, and let me tell you, in the coastal regions, this is even a bigger challenge because of humidity in the air. But I do not have answer for this because I am not aware of the duration part. But normally what we suggest is, in my practice at least, when a patient, we actually ask them to do the first fingerprint in front of our educator, We ask them that you do first glucometer check in front of us. Then what we do is we put a fluorescent sticker on the lid of the strip, and we clearly explain that whenever you close the lid, put this fluorescent sticker over back again. So if we see damage in the fluorescent sticker, that means lid ज़्यादा time के लिए खुला रहा है. So this is a Indian solution what we follow, but I do not have answer, sir, ki exact how many hours, but definitely I'll look into it and I'll try to address it. But that's a very important concern, and especially in humid areas, it's even more, because of the humidity. Many times we have seen the change of color of reagent on strips. This also we have noticed in past. So very important context, sir. Thank you.
Thank you.
All right. Thank you. Thank you so much.
Thank you so much, sir, for